Hi everyone, welcome to ResearchMD.com. We got a great presentation today. We're going to look at a recent article published in Lancet, Rivaroxaban versus no anticoagulation in the patient with post-COVID-19. The trial is called Michelle trial. So we're going to do a critical analysis of the paper. Again, my name is Pramil Cheriyath. I'm a program director, internal medicine and transitional residency, and I also director of research, and I'm also assistant professor of medicine to large medical schools. So let's look at our presentation. This paper was published, and the title of the paper was Rivaroxaban versus no anticoagulation for post-discharge thromboprophylaxis after hospitalization for COVID-19. And then below the primary author, we want to recognize the primary author, Dr. Eduardo Rama, COT, physician, and then so sponsor Silence Valley Research Institute in Brazil, and Bayer also make Rivaroxaban our sponsors. So if we look at COVID-19, a lot of information is coming out. The people with the COVID-19 are very high risk for thromboembolic events, right? So previous studies COVID-19 have shown that at high risk for thromboembolic events. So that's where we need to investigate it. So if we look at Rivaroxaban, this is Rivaroxaban is a factor Xa inhibitor, anticoagulation. The list price is $492 per month. And the mechanism of action is like Rivaroxaban comparatively inhibit free and clot block factor Xa. So it's a factor Xa inhibitor. So if you look at this coagulation cascade, you got the intrinsic and you got the extrinsic pathway, and they all join, and then 10 is converted to 10A. That's what inhibition of Rivaroxaban inhibit factor 10A. Okay, so pharmacokinetic of Rivaroxaban after oral administration. Rivaroxaban rapidly absorbed, reaches plasma concentration in 2 to 4 hours, and bioavailability is 10 milligram dose is like greater than 80%, and the terminal half-life is 5 to 9 hours in adults and 11 to 13 hours in the elderly. So elimination, they are eliminated in the urine like 36%, active renal account for 30%, and glomerular filtration 6%. Approximately 230 subject to metabolic degradation, and Rivaroxaban metabolized by several cytochrome P50 enzymes. Okay, so method. Let's go back to the study. What's the method? It's an open-label, multi-center, randomized control trial conducted 14 centers in Brazil. So intervention in patient with high risk discharge after hospitalization due to COVID-19, thromboprophylaxis with the Rivaroxaban 10 milligram per day for 35 days. Okay, that is what they're looking for. When you look at the outcome they measured was like the primary outcome. They used the intention to treat analysis. They looked at the symptomatic or fatal venous thromboembolism, and they used the asymptomatic venous thromboembolism, bilateral lower limb venous ultrasound, and CT pulmonary angiogram. And then they looked at the symptomatic arterial thromboembolism and cardiovascular death at day 35. And then primary safety outcome was major bleeding. The primary safety analysis carried out intention to treat population. So if you look at the dosage they use 10 milligram tablet, can be taken without regard to food, 50 milligram. So they used only like 10 milligram in this study, okay? And then what are the outcome in this study? After they did it for 35 days, they found out like the patients allocated to the Rivaroxaban group and patients allocated the control group. They did the comparison and yielding a relative risk reduction of 67% in the primary efficacy outcome. And when you look at the fatal venous thromboembolism, there's also a big difference. And symptomatic venous thromboembolism, all-cause mortality was looked at it, and that didn't show much benefit. But the composite symptomatic venous thromboembolism, myocardial infarction, stroke, or cardiovascular death, there's a huge difference also. So primary outcome, again, we got this nice table over here. If you look at it, Rivaroxaban group, 159 patient in the Rivaroxaban group, and there's control 159 patient, and primary efficacy outcome in the Rivaroxaban only 3.14%. Okay, in the control group it is like 9.43. So relative risk reduction, the relative risk is 0.33 with the confidence interval 0.13 to 0.90, and the p-value very significant at 0.0293. Okay, and So we got the nice table, like all the other subgroup analysis also done. So what are the strength of the study? Strength of the study is, again, it's a randomized, multi-center, open label, placebo controlled. So very study. Okay, it's also scientific study. It's like it's done really fast. It's like huge importance of people dying with the COVID left and right in the word. So it's very important to do this kind of studies really fast. So it was a fastly done study, well-designed statistical methodology, calculating the sample size, and use intention to treat analysis also for the analysis. Very good. And they use improved VTE score, venous thromboembolism score, to see which patients are high risk. And so that is also, those are the strengths. Okay, let's look at what are the weakness of the study. If you look at the weakness, they excluded the patient with only active cancer. I think they should have excluded all the patients with cancer, and should have excluded people with the CHF also. Studies have also shown in hospital, when the patient comes with CHF, they are high risk for blood clots. Okay, and then testing for statistical heterogeneity. See, what happens is, when you have so many multiple centers, you need to do this heterogeneity test, see, to make there's no big difference between the centers. In this study, I did not see any heterogeneity test. And the people, when they discharge from the hospital, every patient should have undergone ultrasound of the leg and a CT scan to make sure they did not have a PE. And then in control group, when you did the analysis, or when you did the finding, they were looking for everybody after day 35 got a CT scan and pulmonary embolism, but not everybody got it. In the control group, only 159 out of 90 got CT scan, and 118 got Doppler ultrasound. So there's some people left behind. In the treatment group, 159, 114 got CT scan, and the other only 134 got Doppler ultrasound. Okay, there's some people missed, could have affect the analysis also. And also very important, like, what is the ambulatory status of this patient in the hospital? Were they getting physical therapy? And when you discharge, they go to rehabilitation, where they were continue to get physical therapy, or they actively mobilizing, or they were going home, resting. Those kind of things also very, very important. Okay, so we calculated the number needed to treat. We did the absolute risk reduction, risk in the control minus risk in the Rivaroxaban. That is, absolute risk reduction is 0.029. So number needed to treat, the formula is 1 divided by absolute risk reduction. So 1 by 0.06. So you need to treat 15 patients to get benefit for one patient. Okay. In conclusion, inpatient discharged from the hospital, high risk patient discharged from the hospital. If you give thromboprophylaxis with Rivaroxaban, 10 milligram per day for 35 days, they improve clinical outcome compared to no extended thromboprophylaxis. So it is very beneficial to treat the patient with Rivaroxaban because it can decrease the thromboembolic event in the patient with COVID-19. Fantastic study done by great authors, even though we have some weakness. Thank you so much for watching today. We'll be back with another presentation soon. Thank you.